You're tuned in to RX Radio.
Because it is the one nice part about social media is the free access you get to people injuring themselves around the world.
Yo, people love to post that shit.
Have you followed, and I don't know if I've told this story on the podcast, but it's fucking epic. So the one, James McIntosh, co-host of RX Radio,
yes.
He was staying in my place in Miami years ago. Years ago now. And I had no furniture. He came over from Australia like 2 days after I moved in. I think we both had a mattress on the floor in either room. And then at night when we would come home from training, we would just lay on the floor with our feet up on this like little rung of this bar that I had in the middle of my living room. And one day he just started like hysterically laughing. And I was like, dude, what the fuck is going on? And he shows me it. And it's the Instagram page, Kids Hurting Themselves.
Oh, dude. Great follow.
Heard?
Yeah, it's a great follow.
But here's the funny part of the story is he shows me the video and it's like 6 kids operating some sort of human catapult. Some sort of, there's no, like the only way you could describe this device was it was designed to do the thing it did, which broke both of the kids' arms. So the kid fell and he had two, you know how I know the kid had 2 broken arms? Because the video was of my ex-wife's nephew. I was literally like, wait a minute. Like that kid looks really familiar. And it was like 6 kids holding a rope, like on some Little Rascal shit. The rope was like tied around like a really high tree branch. And then there's a kid like swinging for some reason. And he swung until he hit like, peak angular velocity and then just fucking dropped the rope and just fell like 2 stories. Oof. And I look at like the submitted by, it was submitted by his dad. His dad submitted the video. And like, I know, obviously I know it was the father that submitted it. I was like laughing my ass because it's like, typical laid back Australian parenting. Like they'll be fine. It's whatever. And I go and I see, and it's like, I see the aftermath and it's like, poor kid had 2 broken arms. And I was just like, oh, geez, like the injuries that you see on Instagram, it's enough. Like, can you do it? Like if there's like there was one and I still haven't watched it. It was like people call it a sissy squat machine. It's definitely not that. It's like the thing where you hook your feet into the little floor mounted unit and you do like a closed chain quad. About. Have you seen that one?
Gnarly, dude. It's fucking.
You watched it?
You can literally see it.
I can't. I've seen that thumbnail so many times. I've had that sent to me. I can't do it, man. I can't. After my own injuries, like after my pec tear,
yeah,
I'm out the game, dude. Because I feel it. I swear to God, when I'm like the next day, I would wake up and I would feel. I mean, it wouldn't feel obviously the same magnitude of that, but like my knees would hurt. Like literally watching that. I can't. I'm so bad with that shit.
I'm bad in the other way. Like I love watching people get hurt. I fucking laugh first and then check if they're okay after.
Really?
Yeah,
that's
dude.
Like what was that show? Most Extreme Elimination Challenge. Do you remember that?
No.
It was like when Japanese TV first started making waves in America. It was on like 3 a.m, dude. It was like an obstacle course race. Like think American Ninja Warrior meets.
Right. Oh yeah, I know what you're talking. I've seen
kids
like
hurting themselves.
Other versions of the show. Yeah, for sure.
Yeah, I can't, man. I'm out, and for me, and I've always been a little bit like squeamish with that. Like violent stuff, World Star, light me up. Anything in the gym, sanctimonious. Like, yo, the Diddy domestic violence is wrong. Just getting that out the way.
Yes.
That type of World Star shit. Like there was one NASCAR one the other day where 2 NASCAR guys started like one guy just punched the dude in the face for like running him off the track. Street fight stuff, yes. World Star, yes. Yeah. The Diddy one was like that was almost a line for me.
I didn't see the Diddy one.
Oh my God, dude. Are you joking me?
I haven't seen it.
Okay, so I'm going to set the scene for you and we're going to talk about training in a minute. But it was the most insane, like domestic. He was there in like a hotel, hallway where it opens up to where the elevators are. And you see like a female running down the hallway with like a duffel bag. And then like on some Animal Planet shit, you would have thought David Attenborough was going to be commentating this. Diddy comes flying out the room with a towel on, like just out of the shower or something. And like, dude, it was bad. Like, and all the comments were like, oh my God, could you imagine what he did behind closed doors? I'm like, can you imagine what he does with pants on? Dude threw down World Star style in public.
Oh, fuck, man.
Holding the towel. Dude, I can't brush my teeth with the towel wrap without it falling over. And my thing is like, you're so afraid of people seeing your dick, but not afraid of you beating the shit out of a woman in public?
Not okay.
Like, where are your priorities? It was, dude, if he had like some dry fit compression pants on, he would have kicked that lady's head clean off her body.
Jesus.
It was going down it was like not okay. That's where I draw the line. Everything in front of that.
Violence towards women is definitely where I draw the line.
I think that's a great line. And we stand behind this message here at RX Radio.
Yes.
But everything, there's no better video than like a swift justice man getting punched in the face video.
Oh, I love street fights, man. I fucking love it. Love it.
I love the underdog. I love when like there was one dude I saw. I think Josh Bryant posted it. It was a guy. He was from Thailand, somewhere Southeast Asia, and he was a gas station attendant. And guys had come in and like came in with guns and they robbed the place or whatever. And he went in pursuit. But he was like a 5-time world champion Thai boxer or something. And like 4 guys got away. And like I don't know, he grabbed the fat one or whatever. And like, after a few moves, a couple guys with guns were just like, good luck, dog. We'll see you. Hop in the coupe, and out they went. And the guy just was in for a bad day. There was another one. I could do it all day. You see the vape store one where the guy tried to rob the place and they just hit the button and locked the door. And then the 3 guys kind of like slowly, like nonchalantly hopped over the counter. And the kids were just like waiting at the door and they're looking back. And this one guy's literally just taking his time. Like he's going to enjoy this and hops over. Oh man, the best. But I think I actually posted the video years ago of my pec tear. And that for me has changed my interaction. Anything in the gym now, I can't do it. Can't do it. Can't do the gym fail stuff.
I'll watch them all. Every single one of them.
Have you
not the beating the girl in the hallway, not that, but the rest of them.
Your back was the worst gym injury you've had, right?
I've had, probably. I've had a pretty gnarly herniated disc. Re-racking a jerk. I had a partial tear in my quad tendon on the platform. So both those are probably my 2 worst, like, actual training injuries.
Now, from a clinical side, what have been the worst injury? Oh, God, you've probably seen some of the worst on the planet now that I think about it. Some of the worst ones that you've had to rehab.
I've seen some gnarly ones. I think you know some of them, too. Yeah, I've seen, like, I've had people walk in off the gym floor, torn ACL, like, broken tibia, dislocated shoulder. I had a C1 burst fracture. That's a gnarly one, yeah.
Oh, yeah, you told me about that.
It's fucking gnarly. That one's trash. Actually rehabbed incredibly well, like full function, no paralysis, which is the thing you kind of want to worry about when you have a C1 burst fracture. Like torn adductor into abdomen, like a Volsion pelvic fracture, you know that one. I've seen some pretty bad ones, like hernias, hip labrums, SI, ton of herniated discs. I've seen some shit, yeah, for sure. Like ACL, meniscus is one I've seen relatively often. If you can think of it, I've probably seen it over the past, I don't know how long we've been doing this, a decade now.
Man, I remember the one we worked on a knee together, combine, PCL, ACL, MCL, LCL, ALL, medial patellofemoral ligament, and full rupture of the gracilis.
Yeah.
That was like, but here's where I kind of want to take this is like, I kind of like the shock factor of all the crazy bullshit that we've seen. Like for those of you, look up a burst fracture. Did the person have a halo brace?
Oh yeah. Yeah.
Okay. So if you guys are unfamiliar with some of these injuries and you feel a little bit of pain going into the gym, understand that like, okay, we've successfully rehabbed the craziest injuries that you can physically rehabilitate without surgery. And the halo brace is probably the most gnarly medieval medical intervention. So like the fracture is basically like where your neck meets your skull. And if one thing goes wrong or moves the wrong way, like you're a quad, right? Like you're a quadriplegic, like arms, bye-bye, legs, bye-bye, anything that's not mediated by cranial nerves, like you can pretty much say goodnight to. And the halo brace, and you could probably speak to it better than I could, but it's the pins in your neck and then in your head.
Yeah, I don't know if it was the hard pins on this one, but yeah, it's like it's a neck brace and then a fucking like literal halo, so that like everything from your shoulder girdle to your forehead moves as one. Yeah, like you need to look over your shoulder, you're turning 90 degrees.
Yeah, it would honestly look like they were auditioning for a new member of Slipknot or something. Like that's what it looks like. That's how gnarly the mask is. But to maybe a lighter point, there is a path forward in way more cases than most people actually realize, right? And when you start to get into this and when you start to look at some movement principles, some principles of training and rehabilitation, what you realize is that there are cases where, yes, obviously surgery is going to be the preferred method. And there are times where the time frame of rehab, where you need to sacrifice, in the case of sports and athletes, like you will sacrifice long-term outcomes for short-term outcomes, right? So there are oftentimes cases where long-term outcomes are very similar between getting a surgery or going through non-surgical rehabilitation, but the acute timeline is more favorable. So, this is not going to be an anti-surgery podcast. It's about an understanding the limits and maybe understanding that they might be a little bit further along than you think when it comes to actual physical rehabilitation and injury. Because exercise programming, there's so much in the social media sphere right now about technique and execution, which I think is great. But on, when it comes to rehabilitation and injuries, exercise programming is the fundamental principle of biomechanics that we need to really pay attention to, because there's a lot of talk about load management and allocating stress to particular tissues and full range of motion and all this, which is great, but picking the right exercise is going to be the tool, especially when we're dealing with acute injuries. So I kind of wanted to lend some insight on all right, we are going to discuss how to program for pain management. It's sort of like a step-by-step process. So if someone comes to you just off the gym floor, and we'll go general injury, what are kind of your stages that you walk through with this person to bring them back to full function?
Yeah, that's a good question. I think it all starts with understanding the symptoms, especially if it's something that it's more fresh, you haven't had imaging on. Imaging is always more information. It's not always necessary, though. So if it's someone like high stakes, like we're talking NFL combine, like, yeah, you better get some imaging done just so you have all the information that you need. But a lot of people, that's, maybe they don't want to do it. Maybe it's not realistic. Maybe it's not convenient. They want to try going the conservative route. So the thing that has been most helpful for me right out of the gate is understanding the symptoms. So it's always going to start like history taking. I want to know exactly how the injury happened. I want to know the onset of pain. Is it something that crept in slowly? Is it something that happened suddenly? Was it an acute injury? Is it something that hurts worse in a particular movement or at a particular time of day? And all of these things give you information into the actual structures or the mechanism of the actual injury, what you're dealing with in terms of rehab. Aside from that, really understanding the pain pattern that they're having. So the questions are always, what makes it feel better? What makes it feel worse? And then are there things that you do that don't necessarily affect how it's feeling? So that's all information that tells you, okay, like if we talk active versus passive range of motion, that's one thing that we can use to start to rule in or rule out specific structures that might be injured. So if we're talking a muscular injury, that's something that's probably going to be worse on a more active range of motion, something where they're contracting that muscle versus something that gives them pain or discomfort on passive. It might be a passive joint structure, something more ligamentous, joint capsule, inflammatory, that sort of thing. So for me, it always starts with understanding what you're actually dealing with. And if you have some sort of working understanding of what these injuries are or how you've been able to manage them in the past, then you want to overlay those two things. And that gives you at least a starting point. So if we're talking something that we want to work short-term rehab, where we're trying to get progress out of this person relatively quickly. It's definitely understanding that and then letting that be the bounds on your programming decisions. There's going to be certain things that always make it feel worse. They're going to aggravate the symptoms, and a lot of times they're going to be things that are consistent with the mechanism of injury, right? If they had, I don't know, let's say a quad tear, a quad tendon tear, something I'm very, very familiar with. All right, they're probably going to have a hard time eccentrically loading that quad, getting into deep knee flexion, things that are going to put a lot of stress on that quad tendon. So that's something that we're probably going to avoid loading in that short term. And we're going to find things that we can do that will stabilize them through that range of motion while taking stress off of that injured tissue. So a pattern that I like to go through, I typically, when I'm working with people that have injuries that are on the more acute side, and this kind of falls with chronic too, but I'll start with more isometric or more static movements and get them in positions, and that gives them an opportunity to learn how to coordinate stability in those positions. Like one that, or two that I've been really leaning into for the lower body lately are just an isometric lunge hold. And I did this last week a lot when we were in Tampa, is like a staggered stance RDL, but just a static hold in that hinge position in the greatest degree of hip flexion that we can get them in. And what that does is it allows them time to understand how to stabilize the lumbar spine, how to stabilize the hip joint itself, and then learn how to build awareness around foot pressure, which is, they're the things that I look towards to being effective in creating and expressing force through the lower body. So it's really, in my mind, understanding the things that are going to flare up the injury, making sure that we're avoiding that, we're keeping those out of there, having something in that is going to be low risk to get them to build awareness around positions that are going to be safe and start to stabilize positions that we'll be able to load over time. And the progression from there is, I want to start static, build a really good understanding of how to create stability in the less stable portion of the range of motion. And then it starts to go to dynamic through a range of motion that's not necessarily going to complicate or worsen any symptoms that they're having. And then the progression back towards activity, it's for me, it's always going to be volume first. So we want to build up endurance in these positions, their capacity to hold these positions, independent of load. And then after that, once they have an acceptable amount of endurance or ability to move in and out of these positions, before that's going to be range of motion. So those two I blur the lines on depending on symptoms. So range of motion and volume, we want to move them. We want to increase their endurance, but we also want to increase their range of motion. So that's like, those are the two that will limit their loading progression in my mind. So unless we can get as much or full range of motion out of the movement and we can build a reasonable amount of endurance in those positions, then I'm not going to introduce load, because we can still have a lot of progress on those things while keeping it relatively low stress. And once you get them to the point where moving through full range of motion, no increase in symptoms, there's a reasonable amount of endurance to hold those positions through increasing volume, then it's going to be starting to increase load, going through some sort of loading progression, and then getting them back into like adding speed to the movement, making it more dynamic, change of direction, that sort of thing. What I've seen, especially working like with a more athletic population, injuries that are going to happen in the gym are going to happen when someone doesn't have the capacity to manage eccentric load. So that's something that I think the isometrics become really important in, is because it puts them in a position where they're starting to build their capacity to manage eccentric load, to stabilize these joints in positions that might be less stable, so that as we start to get back to increasing loading and increasing speed in the movements, they now understand, or they have a layer of awareness of how they need to coordinate those movements so that they can stay safe in those positions. So that's kind of like that's a pretty general overview. We can expand on any of those things, but yeah, I'll pass it back to you to kind of see what your thoughts on it.
I think one of the things that really helps out of the gate in undergoing the process of programming post pain or post injury is instilling this idea, and it can be difficult in the start, but getting very confident with instilling the idea that the goal isn't perfection, that the goal is just sucking less, and that really, and it's a kind of a negative compliment. It's like, oh, you thought you were functioning at 100%. Like, no, like you were at 51%. and now you're at some threshold below 50%. These are all arbitrary numbers, of course, just to kind of illuminate the point. But it's like the goal is just to get you back to 51%. And then once you're out of pain, we can really start to push the needle, right? So I think people think that 99% is where pain exists, and that 100% and optimal is where you're going to see all of the benefit, where you're going to be pain free. It's like, or sorry, 100% is pain free, and then 99% is where everything falls apart. It's like, no, most people are not, accurately assessing, for their load management and exercise programming. They're not in a more microcosm. They're not accurately assessing for, load management in technique and execution on particular tissues, right? Are you loading more inert soft tissues rather than muscles when you're performing these movements? Does the aggregation of these ill-performed, ill-prescribed movements start to collect to some sort of tipping point where you now start to feel pain? So I think instilling that out of the gate. So someone comes to you like, I have an injury, whether it's a herniated disc, whether it's an ACL tear, whether it's whatever, and you can just go, okay, like the goal is 51%, right? Now, so that's, I think, a really good benchmark to establish, is that we don't need a lot of progress to get you out of pain, because you were operating pain-free for a long time and you weren't operating anywhere near 100%. This is where getting information about how they used to move. Now, works better if you've dealt with the athlete or person prior to, and they've become injured. That way you can be like, look, you kind of have a tendency. We know your lacks of range of motion. We still have things to work on. So having some sort of retrospective data on movement quality, I think, is really useful, whether it's by way of like old lifting videos, whether it's by way of, you coaching them in the past. Hopefully, if you're coaching them, you're paying attention to these things that matter. They're not getting injured as much. We're mitigating that risk. And we know how to downregulate when symptoms become present. But getting retrospective data, I think, is super useful in the selling point of like, look, this is dog shit. Like, you're lucky you didn't hurt yourself before. And it's like, oh, okay. Because I think that instills some hope of like, oh, I don't need to return back to 100% because I was never there to begin with. I'd be so happy to get back to where I was before. And then when you set the mile marker there in the initial stage, like, dude, we can get you back to where you were before, but we can actually get you better by paying attention to these other movement qualities that you don't seem to possess given the retroactive footage that we have of you moving, or assessing the non-injured side. Right? Like, here, we're going to assess the non, so your dog shit over here. Oh, this is your dominant leg or arm or whatever. There's no way you had this movement quality present in your injured side. Now, look, injuries come in many shapes, forms, and fashions, and it's not like we want to be the injury whisperer. I don't make a habit of like saying that you could have prevented things from happening, but give someone tangible mile markers, because I think that one thing that I want to add to yours, because one of the first things you said was like managing the symptoms, is understanding the signs. And that's the objective piece, right? So you need to listen to the subjective. And like, if you're not familiar with this verbiage in a conversational setting, I would suggest you sit for 5 minutes and really understand that when we say subjective, we're going to mean symptoms, and it's going to mean what they tell us, right? When we say signs, this is going to be objective, and this is what we see, right? So a good plan tailors or takes into consideration the subjective and the objective. So yes, what they feel is going to be one of the guiding principles, but it has to coincide with a learned standard of movement qualities on the exercises that we choose that best fits where they're at, like you mentioned with the passive, active assisted, active, and active resisted spectrum, and their ability to tolerate load for longer periods of time at certain intensities and at certain velocities, endurance, intensity, velocity. So it's really, I think, some important pieces to look at when you're initially drafting the program is going to be like, okay, give me a retroactive view of what it is you look like, how it is you move, right? What did this look like before things went bad? What does it look like now, if possible, to reproduce, whether on the involved or injured side, in hoping that it's a unilateral injury, not a bilateral injury. And if it is bilateral, be like, all right, let's see what this used to look like when you were performing it. Let's see what your squat used to look like if you have videos, deadlift, and then so on and so forth. Or something more dynamic. Let's see what your pitch looked like. Let's see what your kick looked like, or whatever. So I think that's something out of the gate that I think is super useful. And from that, really, I think sets the stage for the most important piece of this entire programming for pain part of your job, which is setting realistic expectations. It's a first date. Under promise, over deliver, right? You know what? Oh, you got time. You got time to do the Michelin joints, right? Don't go Michelin. Just trust your boy here. Done it. Bit me in the ass. Where do you go from there? You got to go third date. You're on 3 Michelin star. Dog, you're broke. Value menu. First date. You're welcome. Take that. That's from me. Value menu. Anything you want, sweetheart. Anything off the value menu. We're going to build, right? We're going to build this. So that is the number one thing. So everything when it's talking signs and symptoms, all the data we're collecting, when we're talking about, what do their previous movement standards look like? We're going to talk about where do we really enter into the conversation as far as prescribing that first step in exercise or therapy and rehabilitation. What is our first piece that we're going to put on the board? And really having conversations like this or having internal dialogues about this is about being able to move confidently and swiftly towards that first move. Right. And that's where you start to really gain the valuable experience. So if you don't have a framework, totally cool. We've established ours over, collective 20 years plus of doing this, but establish a thought process so that when someone walks in your door and they go, I've had this injury, I'm now looking to get back, I need you to help me. You go, great. We're going to look at signs and symptoms. We're going to look at how you used to move, right? We're going to maybe do an injury history, which we talk about in the level 1. We're going to figure out where are you on the damaged tissue continuum. Is it is it painful passive? Is it painful active assisted, active resisted? Is it painful if we try to move things heavy? Okay, let's scale it back and do endurance. And then the whole idea is literally coming up with a mad lib of an exercise. Okay, let's try this. Yeah. Ow, that hurts. Okay. This exercise has a regression. And we just flip through the pages of our exercises that fit the consistent mechanism that we're trying to drive in these early stages just to put a piece on the board. So first step number 1 is going to be managing expectations. That's where I think a lot of what we're saying, if we were to summarize the ethos of some of the bullet points we put out, that's number 1. Number 2, it has much to do with training as it has to do with lifestyle. And that's just understanding what we know about pain management. Because I think before we go too far, we have, and I get in the habit of doing this, talked about pain and injury ubiquitously as they're the same thing. And they're not. An injury indicates a certain level of damaged tissue. Pain is a process, it's a signaling process. It's a warning sign. It's a light on the dashboard. We have to heal an injury. We have to unlearn pain. This is something that surprises a lot of people. Talked about this just actually in the last week of the L1 that just finished last week. Was an acute phase of an injury, depending on who you ask, is going to be at max 72 hours. That's acute, max. I would say 48 hours is that's the acute phase of most injuries. Subacute is from 48 or 72 off to 10 to 14 days. Chronic starts at 14 days. Most people, when they think they have a chronic injury, chronic sets in at 6 months or a year. Oh, I have this chronic injury. It's at 2 months, at 3 weeks, you have a chronic injury. And it's because it's the pain perception of an injury that's the thing that we have to get on top of, right? So this is the other side of the coin. So we can go in and we can do our logistics, we can do our due diligence, we can start to write an exercise program, but there is a ghost in the machine when you're dealing with injury, and that ghost is pain. And this is where you have to secede some territory to manage pain as best we know possible. Pain is very complicated. You can go down some more biochemical signals. You can go through emotional and trauma stuff, which I don't know anything about. I know a lot about it. I just don't know how to deal with it. So that's why you're in my life. Or you can deal with the biomechanical or the more mechanical stuff. Pain is an emotion, a drive state, and a perception. So it's very complicated. It sort of exists in our somatosensory cortex, which is part of our prefrontal cortex, which is where all of our baggage that you dump onto other human beings is just in this part of the brain. And pain lives in there. So that's why you have this really narrow time window to get ahead of it. And I think if you're dealing with someone coming into an acute, chronic, or acute, subacute, or chronic phase, wherever they are, it's what can we do to manage pain, right? This can be going to preferences. What do you like? What has helped manage pain? Big ones are always, and this is true of every injury, is going to be sleep. Yeah. Whatever this person needs to do to get to sleep is worth it, right? Shy of I don't know, potentially ODing on something, like get that fucking person to sleep, right? But so you might have an injury that impacts someone's ability to sleep. And what needs to be done is to figure out a way to supplement this pain for a small enough window for them to get sleep. Now that could be going for walks, that could be getting away from screens if it's a head injury, that could be elevating, that could be getting a new mattress, whatever it takes. Get that fucking person to sleep. That is if there's one thing that we can say confidently about pain management, it's that. So looking at habits and lifestyles that can help alleviate the perception of pain, and I'm choosing my words as careful as possible, so that this person can get regular, good quality sleep. Next thing, the role of exercise in pain management. Pain or exercise exhibits a property they call exercise-induced analgesia, which is like it hurts less when I lift things. Now, obviously, we're going to avoid the damaged tissue, the painful areas. We're going to avoid any sort of lifting that is potentially bothersome. In an acute phase, right? In an acute to subacute phase, we might allow for a certain level, and we've done a podcast on this, a level of discomfort, and knowing and being able to verbalize the difference between pain and discomfort, I think is a really big step in the early education process of pain management and exercise programming. So what we want to figure out is like, okay, locally at the area that we're addressing, what are our short list of exercises that we can start to put a piece on the board? How can we start to restore full range of motion, either passively, active assisted, active resisted, with the goal being going right up to the threshold where they start to perceive pain. I want to pick that intervention or that exercise as close to that person's threshold of feeling pain as possible, and then slowly and incrementally through graded exposure start to move from passive to active assisted. Right, or move from, and we haven't discussed this, sagittal to frontal, or frontal to transverse, or high endurance to high intensity, or high intensity to higher velocities. I'm always trying to move these three variables in training incrementally, whether it be type of movement, passive, active assisted, active resisted, whether it be stimulus of movement, endurance, intensity, velocity, and then rhythm, coordination, timing, and then the type of, what have I said so far? Oh, and then the type of plane we're moving in, sagittal, frontal, transverse. We're trying to just fill these cups so they don't spill over every single time we're in a session. So on top of that, what we're trying to do is do that within the threshold of pain, and then trying to make sure that, look, locally, these are the things we're equating for. But globally, it's like kind of go nuts within the limitations of whatever injured area you have. Right? Exercise-induced analgesia, it's going to help with sleep. It's going to help with acute pain management. It's going to help break the pain cycle, the learned experience of pain. It's going to, you're going to talk endorphins, you're going to talk biochemical mediators, you're going to talk neurotransmitters, all of these things, which are going to boost metabolism, all of these things are increased circulation. These are going to be things that help manage and break the cycle of pain, which should be, and it's hard to rank these things 1, 2, they're both number one. Manage expectations, which is like kind of the psychological aspect of putting together an exercise program for managing pain, and then actually do what is physiologically possible and proven to actually manage that pain, right? So I think those are some overviews. If you're going through this endeavor, these are things you have to be checking on every single day. Like you need to be making sure that when this person walks into your office or in your gym, that you are equating for all of these. What are the signs and symptoms? Because I think a lot of people do great first initial histories, and they talk like, oh, how did it happen? What's the pain out of 10, or what's the percentage that's bothering you during a day? And then they kind of pick their exercises and they just go. It's like, no, that's every single day. Like when I'm dealing with football players in season, their exercise programming is a return to play protocol every single week. That's how you look at it. Every single day they walk in, it's like your 10-second Tom from 50 First Dates. You ask them the same question again. You document it, and you see like if they're a 0.1 subjective interpretation of their pain higher, what has changed? What do we need to do? Right? It's a very sensitive endeavor that requires a ton of understanding. Listening's not enough. You have to understand, which means you're listening and making changes to what you're hearing. So I think those are some things to keep in mind when you go through this process in the acute phase, is like, manage expectations. How do you do that? Well, see how they were moving before, see what our benchmark is to get back to some sort of semblance of prior function, and then let them know that, look, probably weren't functioning as good as they could be, and that the mile marker is a lot further or a lot closer to us than we think to get them out of pain. Once expectations are managed, then we go through the process of like, our goal is to the best of our ability, manage the perception of that pain and break that pain cycle.
Yeah, I love it. And just to weigh in on kind of that idea of through the rehab process or through the introduction of exercises to get them back to returning to play, you made that point about you should be bringing them right kind of as close as you can to that point of pain and then backing off. And that should be a progressive effort over time. The way that I like to think about that and manage expectations around that is it's a very similar thing to what you're saying about if someone's functioning at 50%, the goal is 51%. There's a relationship between function and pain that creates a threshold. Once function drops below a certain level, they're crossing that pain threshold and they're going to be in pain. That's a pretty general statement, but it holds true in most scenarios. So I think of it in the exact same way, but the way that I'll explain it is that you were operating at a level of function that you were able to operate without pain. You now have a decreased level of function, and maybe there's tissue damage or maybe there's something else that's contributing to that, but you're now below this pain threshold that you're experiencing pain. So the flip side of that is that the goal is not necessarily to get you out of pain, but is to create as much of a buffer above that threshold as we can as we get into this phase of rehab or this rehab plan. The goal is not necessarily just to get out of pain, because there was a level of dysfunction present before you were in pain. So the goal is not necessarily just to get you out of pain and then go do whatever you're doing. It's no, now that you've had pain, you've crossed that threshold, you're probably predisposed to continue to have this injury in the future. So there needs to be some sort of foresight around this so that you can create a greater and greater buffer above that pain threshold, so you have enough function that you're not going to dip down on a day where maybe you didn't sleep, or maybe it was a hard practice or a heavy session that just dips you down to that point where you're not recovering enough that you're now below that pain threshold. So it's not just, and this is how I think of rehab on the whole, which I think is something that's forgotten in a lot of cases. A lot of practitioners, whatever they're doing, they'll get someone back to that level of function that they were at previously, and that's success. That's not the goal. The goal is to create such a buffer of function above that pain threshold that this isn't even a consideration moving forward. And that might be something that they have to do for the remainder of the time that they want to pursue whatever goal it is they're pursuing. Like for me with the disc herniations, the knee injury, ankle injuries, like there's lower body accessory pieces that I have to have in my program at all times, or else it's just going to crash and burn eventually. It's just a matter of time. Same thing with, dude that we saw at the combine that blew out everything that crosses his knee. Like there's going to be things that you need to do for the rest of your football career to keep you above that pain threshold. And if you stop doing those things, then it's going to creep back in just because of the lack of structure or because of the biases that came from that injury. So it's not necessarily just getting them out of pain. It's understanding that there's a relationship between function and pain, and the greater function that we can create in an area, that's going to take them further and further from that pain threshold. And then along with that, I think something that's important, because you did mention like 14 days being a chronic injury, chronic pain. There's something that we can do in phases of training where someone is in, maybe they're in a knee brace, that maybe they had an ACL reconstruction and they're non-weight bearing on that side. I think an important thing for anyone who's dealing with someone that's in that situation is to have a bit of foresight around what can we do now to be productive. It's not just rest. Rest is not the answer. There's always things that we can do. There's qualities that we can start to create or buffer or create a greater capacity that are going to prevent things that we know will happen from this person being one side dominant for 6, 8, 12 weeks. So they're going, if you're non-weight bearing on one side, that's a period of time that you're having literally no proprioception, no ground force coming up through that foot into the hip. You're losing the ability to coordinate everything in that lower body. And not only are you losing that on one side, but you're increasing your perception and awareness comfortability doing that on the other side. So you're going to develop an asymmetrical dominance that's going to, if it's unchecked, it's going to create favoring of the side that you're weight bearing on. So there's going to be things that come with that. There's going to be rotational biases. There's going to be things through the core, compensations through the core, where you're going to basically try and put all of your weight on that one leg, even when the other leg's on the ground. So understanding that that's going to be what happens in this phase of immobility or immobilization, there's going to be things that we can do to create a lack of compensation through that. Or if we understand what those compensations are going to be, then we can start to undo those before they happen, creating better symmetry or creating a capacity to hold better symmetry once we get that other foot on the ground. So I think that's an important part of the process too, is that it's never just resting or avoiding doing anything. It's in a period where we can't directly have an impact on the area that they're having pain or they have had an injury. There's still something that we can do upstream or downstream from that injury that's going to create a better capacity to get back above that threshold, to buffer their function once they get back to that point where they can get both feet on the ground and they can start to train normally. Because how many people have had, I don't know, a meniscus issue or something that's a little bit more minor, like a partial MCL tear, and they're in a brace, or maybe they're on crutches, or they're immobilized for a period of time, and then they just go back to back squatting, but they haven't spent any time understanding the compensations that are going to arise from that, and then maybe they have 70% of their weight on one leg and 30% on the other because they have learned that pain, they have learned that compensation, and now that's their normal. So there's always going to be this period where we have to kind of break that awareness or that understanding of this is what feels normal, and actually get them in positions that are going to be uncomfortable, positions that feel unnatural, or feel like they're maybe all of their weight is on their side that they had the injury on, but that's not necessarily the case. It's just their perception of this is how I've been moving, so this is the way I want to continue to move. We need to break that perception and get them back to a place where they're now creating better symmetry, even if it feels wrong.
Yeah, whether it's pain or performance, coming at training through the lens of learning, I think is so useful. And one thing that comes to mind is the idea of reinforcement. The best cue that you can instill in someone, in whether it's strength or performance, and I'll tell you who's really good at this, and I've noticed it over the years. So shout out Australian strength coach, Sebastian Ora, because the second you watch any of his athletes lift, the second that bar is back on the rack, his fist is right in their face. It's a fucking dab every single time. The dab is the best cue of all time. Nothing will get someone stronger and out of pain like positive reinforcement. Why? Because we need to look at training like learning. We need to look at training like learning. We need to look at rehab like learning. And that's what one of the things I admire so much about that approach. And you don't even know what you're looking at when you're an amateur coach. You just think this guy's super hype. It's like, yeah, but the super hype guy trains like the strongest guys in the world. He coached Marcus Leone, friend of the show. And Marcus just like became this, like, I'm going to call him a real estate mogul because he's not here to discount it. A real estate mogul turned like self-proclaimed strongest Jewish man on the planet. And it's like, he got coached by Bass. And it's about, when you look at training like learning, you understand how important reinforcement is, right? And that positive reinforcement, people are going to learn faster if you're there, set over set, rep over rep, putting them in challenging situations that you know they can overcome. And when they overcome it, high five. And it's like, it's so simple. And fuck, man, I watch so many coaches miss the boat on it. Just a good fucking dab. Just, whoa. And you got to practice the dab. You got to understand the dab ability of the client you're working with. There's the science to the dab is like, trust me, spend time in a weight room with athletes and you're going to know. But that is like the idea of reinforcement comes from not resistance training principles. It comes from the idea that when we are rehabbing or we are strengthening or building skill, that we are learning. And this process is mediated by the same principles that moderate or dictate learning. And then reinforcement becomes a massive part of that. So when you're dealing with people who are shit scared of being in more pain or not getting back to where they think, and you positively reinforce that experience, this is like clinical wisdom shit after doing this for enough time and just looking at all of the subjective stuff, right? Looking at all of the things or looking at all the objective stuff where it's like, okay, I don't get it. He's like getting stronger or, things are measurable. It's like, there's an experience to rehabilitation. There's an experience to strength training that really abides by the principles of learning. And one of the most, ring a bell and I'll salivate, right? Pavlovian style positive reinforcement. That reinforcement of whatever it looks like is going to be something that pushes them along the road, especially in the acute phases. So please, when you do this, understand that whether it's athlete, whether it's patient, it's still person. And that's what you're rehabbing. You're rehabbing a person. You're not rehabbing a knee. You're not rehabbing a shoulder. You're rehabbing a person.
Yeah.
Diatribe.
Yeah, I think a really important part of that also is skewing performance metrics. A lot of people, when they have an injury, they're trying to weigh what they're currently doing versus what they used to be able to do. So if you can assign new performance metrics to that person in the rehab process, then that gives them a different target to aim for in terms of progression. Because I don't know, say, like my quad injury, if my performance metric was my max clean and jerk or my max back squat before the injury, it's going to be a long, hard road to get back to that. But if it's understanding more subjective variables, is were you able to take the first step out of bed this morning without buckling over? Yes? Sick. That's improvement. And it's a lot more subjective along those lines. So breaking it down and really having that conversation. And that's really where this starts for me. Every time I have a session with someone that they're in that rehab process, it's how are you feeling? And you start to dig in on those things that they are feeling. Like, what did you feel when you got out of bed today? What did you feel before your workout, after your workout? How did your lunges go today? Were you able to go more reps, more sets before you started fatigue? Or is it more stable in these positions? How is your understanding of foot pressure? Things like this, having metrics around this. And even if they're very subjective, I like to write these things down or keep some sort of log around them, or even encourage clients and patients to have some sort of pain log around the subjective sensations. But that gives them something to strive for. It shows them that they're having improvement outside of the end goal of, maybe they're not scoring touchdowns on a football field. Maybe they're not hitting their 1 rep max back squat, but you're showing them that there's these tangible things that they're improving on, and they're having progress as they go through this process, which is encouraging. And people need that, especially people that are more in the athletic population or have a very objective measure of success in the sport or the goals that they're pursuing. You need to give them things that they can latch onto, and this is your metric of progress. Did you get through more reps before you fatigued? Or did you have a better understanding of foot pressure? Was it more symmetrical on the video that you sent me? So things like that become really important, because if you don't move the goalpost for them to something that's obtainable, they're just going to get discouraged. They're probably not going to have as good of adherence to the program. They're not going to have as much buy-in, and the whole thing it's just not going to work as well if they're not trusting in the process. So you need to give them things that they can latch onto that show them that this is working, you're having improvement. So be patient and chase these performance metrics as opposed to the ultimate goal being the performance metric.
Yeah, when you talk about latching on, I think a big way to improve buy-in, this is something, we had Andy O'Brien on the podcast and had the very unique benefit of getting to know Andy over the years. And, for those who don't know or haven't listened to the podcast, go back, listen. Dave Lawrence, Andy O'Brien, absolutely insane to be able to talk to these guys. Andy O'Brien's Sidney Crosby strength coach from the age of, 14 or something like that. And one of the things that Andy's taught me over the years is that he gets buy-in through explaining how the exercise is going to translate to their game.
Yes.
So when you say move the goalpost so that you can give them something to latch onto, what I want everyone to take away from that is the idea that what is on the other side of the person latching on to the success of this particular exercise is a few other things that latch on to the thing that they really want to do. Right. So you got to create this link of events that go, the reason we're doing this, and this is where programming becomes so important, is you need to draw a straight line of after you master this exercise for this amount of time or this number of reps, we're going to then move on to this exercise. And then once we go through this exercise, we're going to move into this exercise. This exercise, we're going to load for strength that works through this plan. And this is going to get us, and you should be able to draw that line from every single exercise in your program to them getting back to doing the thing that they want to do. Right. And now activities of daily living, when you're dealing with non-athletic populations, are going to be your foot in the door. This is what's going to wedge open your your impact in a rehab program. When you're taking a history, you go, when do you notice this during the day? You need to transcribe, basic day-to-day activities into the fundamental ones and zeros of like movement code. Oh, when he describes reaching in the back seat, we know that's left to right trunk rotation. Okay, that's present in these exercises. We're going to have to titrate up to that particular exercise, right? So left to right trunk rotation, single arm dumbbell row, probably out the game. What if we did a single arm machine row? Now it's a little bit externally supported. Maybe we're under that threshold. Maybe we're in a discomfort. Now we can start to titrate up that trunk rotation. But the goal isn't single arm dumbbell row. It's some sort of med ball rotation in a half kneeling position or something that creates that buffer that you were talking about. They're not going to see that end game, but you need to remind them, because they're reaching in the back seat because their kids are playing up, or they're their phone fell between their seats. They're not looking at this as some sort of controlled setting where they go, oh, I hope this doesn't hurt. They do it and go, oh, fuck, that hurts. They're not going to notice when it doesn't hurt. So you got to bring that back to them. So getting it documented of like, hey, what hurts walking. I talked about this in the last lecture of L1 the other day. Hurts walking upstairs. You know what I've seen fucking clinicians do? First exercise in a program, step ups. Dog.
Sick.
What are we doing? Why don't you just bring a ladder? I have one. It's right there. Why don't you just bring a ladder and go, oh, hurts walking upstairs. Exercise number 1, stairs. Like, are you stupid? But if you can put that into this programming language in your brain, like a computer program, like you put this into like exercise Python and you start typing out exercises that titrate up to that ability, like, okay, less knee dominance. Got it. Maybe we do hingy stuff, right? Maybe we put them on a downward slope, put on a heel elevation, because that's like they're going downhill rather than uphill, center of mass shit. If you can do that, and then after a week you go, hey, have you noticed anything when you turn in back seat? Oh, you know what's so crazy? I got my grocery out of the car the other day and I wasn't even thinking, and it didn't even hurt anymore. That's so wild. They're not going to notice. Why? Because they got to get the fucking groceries out of the car, because they got to get inside to cook fucking dinner. For the kids that got to go to, they are so just absent-minded. There's other shit to worry about. Walking up the stairs. Hey, how's the up the stairs thing going? Oh, you know what? Fuck, crazy. Ever since we did that like foam rolling thing, I haven't really noticed it. That's wild. You know what? That's so crazy. It's like bothered me every day. And it's because you're walking up the stairs to get your kid out of bed or whatever. You know what I mean? So it's like on you to figure out like as many fucking mile markers as we can. Why? Positive reinforcement, right? They get positive reinforced by the experience, and they might not even know that they're going through it. It's up to you to put that mile marker in their fucking face, that goalpost in their fucking face, so they can't miss it. Just like Sebastian puts that fucking fist right in front of their face, they can't miss it. That positive reinforcement is such a massive, massive part of motor learning. That's a massive part of rehabilitation, because you have to unlearn pain. You don't just heal the injury.
Yeah, I love it. And I think to do this well, you don't necessarily need the background that you and I have. I think you just need to be able to have a conversation and actually listen to what someone's telling you. If you can dig in, you can ask questions around what they're feeling, and you can remember that, and you can take that from session to session. That's the skill that's going to allow you to draw the bounds on what they're feeling. And like you said, remind them when they're not in pain, because they're going to forget that so quickly. So many people have injuries that they don't, say 6 weeks past, they don't even remember what side it was on, because once they're not in pain, they just don't remember it anymore. So always take it back to, remember 2 weeks ago when we did this, you could only do 3 reps before you fell over. Now you're doing 3 sets of 12. So always bring it back to those things that tie it into reality, to remind them that they are having progress, because progress to anyone that has any sort of real goals, it's always going to happen slower than they want it to. But if you can really ground it in reality and take it back to very tangible things, then force them to remember that. But if you can have conversations around this and you care, then you can do this pretty intuitively. You don't have to necessarily know all this stuff. Just care about what you're doing, talk to them as they're going through it, understand what they're feeling. And that's going to be what allows them really to guide you through the process, because you could have this perfect progression mapped out in your head, but if it doesn't work in reality, then it doesn't fucking matter. So let them guide you through the process, talk to them, understand what they're saying, manipulate the variables, like we said, center mass, range of motion, time, duration, volume, loading, velocity, all those things. Understand the way that those adaptations feed into one another. And it becomes really straightforward if you actually just listen to your client and listen to what they're telling you, then you'll know when you need to push a little harder or pull a little bit back. It's not rocket science if you can have a conversation and if you can listen to what they're telling you.
And if you want to learn more, Prescript Level 1 semester starts on what?
The 27th?
5 days from now, Wednesday. So Monday it'll start. So this semester it's myself at Monday here. I will, because this is always going to be a question. So for those of you who are curious, or for those of you who are already registered, I will let you know what the schedule looks like. And Anna sent it to me the other day. So I will be teaching the Monday lecture at 5 p.m. Eastern. Tuesday is going to be taught at 6 p.m. by James McIntosh. Thursday, 7 a.m. Eastern, Killian Hamilton. And Sundays at 11 a.m. Eastern time, Jorge De Hoyos. So 16 weeks long. There's one lecture every week taught 4 separate times to accommodate for time zones and 4 separate perspectives. Right? Mac has a totally different perspective and we arrive at the same conclusion, right? So it's as much about learning how to process thought as the thought process itself, right? So it's not about giving you all the answers. It's about having you ask better questions and getting 4 perspectives on it. We find it fairly useful. Obviously, Killian has his way of going about much more strength and conditioning focus. Matt comes from a physique development standpoint, as does Jorge. And then I kind of bring like a bit of a clinical spin, some of strength and conditioning, and just a bunch of random bullshit stories I've acquired through just running around the planet. So sign up is open now, www.pre-script.com. With that, you get a manual shipped out. Hold on. I have one.
Holding.
It's here. This
There
is it.
That's it.
This guy. So you get one of these shipped to you. The course is 16 weeks long. I'm just making sure that this is the updated one. This is the updated one. Yay. And with that comes what? We're on 7 labs a week. So every single day of the week, if you want to hop on, we have an hour a day. We hop on, talk to one of our coaches, ask questions, get free access to the collective, which is extracurricular sessions, looking at everything from nutrition to sports psychology to program design. One of the things, and this is something that we don't really talk about too often, but when we started Prescript, I wanted to take everything I liked from university, which is actually a lot. And I think universities get a really bad rap these days, but I think if you understand what a university is trying to teach you, one of the things that I really liked, one was the lab sections. So we put those in X number of years ago. So I can go in and talk to someone who knows this stuff and bring in case studies and we can have discussions. And there's anywhere between, 15 to 20 to 40 to 50 people in a lab sometimes on the weekends. And one of the other things I liked was the diversity of the type of content. So even though that this is applied biomechanics and functional anatomy course, you get access to the collective, which is bi-monthly lectures from industry experts outside of applied biomechanics and functional anatomy. I loved my first 2 years of university where they made me take other shit, right? And I think that's, as a strength coach or as a personal trainer, people get very pigeonholed in their approach where it's like, no, again, like you're dealing with human beings. You need to know a broad spectrum. So I like the idea that the collective brings twice a month, you're going to get an in-depth lecture from someone outside of Prescript, outside the industry, just to be like, hey, here's a different topic that you can sink your teeth into rather than just latching to one thing and just doing that. So L1 manual, 16 weeks of lectures, 4 lectures a week, 7 labs a week, collective membership for the entirety of the course. Starts Monday, 5 p.m. with me. See you there. Registration is live at www.pre-script.com. So head over there. We'll see you in class on Monday.
Unreal. See you guys
We
there.
did it. We did it.